Good morning, good afternoon, good evening, everyone. Thank you for joining for this review's webinar. Today we have Dr. Komal Atta. Dr. Atta is a PhD scholar in medical education and director of Department of Medical Education, internationally recognized for her contribution to health professions education. She's a recipient of the prestigious International Medical University Ron Hardin Innovation in Medical Education Award. She has been awarded multiple grants from the Association of Medical Education in Europe and previously served as chair of ME Equality, Diversity, and Inclusion, EDI committee. She also holds a leadership role with the Association for the Study of Medical Education, regional management groups. Her expertise include curriculum innovation, entrustable professional activities, implementation in Global South assessment, and faculty development. With this, I welcome Dr. Komal Atta. Komal, the floor is yours. Thank you.
Thank you so much. So good morning, good evening, everyone. Thank you so much, Sakina, for such a wonderful introduction. Thank you so much, everyone, for having me here today. It's always a pleasure to join any SIView webinar. I've learned a lot from this community, and they're very receptive, and we're always part of something very special. So today, what we're going to talk about is when competence is not enough. The main objective of this webinar is to discuss how we talk about competencies and competency-based education and how we're all trying to form and inculcate competencies into our curricula now. But how is competence actually justified? When being a competent doctor, how do you assess it? Is the only way to assess it through assessment? Where do trust, power, and entrustment lie in medical education? So this is sort of a more focused webinar towards people who are more interested in moving towards entrustment-based practices, towards EPAs, towards implementation of competencies. And I'm just going to give some literature-based and experience-based opinions and thoughts on that, and we'll share things with each other as we move on. Okay, so when we're assessing graduates, when the real question is not really that did they pass the exam. That's obviously good for the university, it's good for our accreditation, it's good for our let's say our rankings, but is that the real thing which we are assessing? The real question is always, can I let them do this work for the patient now? So what we need to think about is, are we actually thinking along the lines of making graduates or medical professionals who we trust to work with patients now? Competence is something which is a property of the learner. So you may be a competent doctor, you may be a very competent driver, you may be somebody who has the knowledge, skills, and attitudes to conduct something properly. However, entrustment is a bit ahead of that. Entrustment is something, in very simple words, that I like to say is whether it's a decision that can you actually give responsibility to this person to demonstrate their competence. So it's slightly different from just having a person who is competent to a person who you can entrust with some sort of responsibility. Now, entrustment comes with risks. Obviously, we are all human. When we entrust our trainees, when we give our patient to somebody else, when we're trying to discuss with other people, there's always a risk that something might go wrong. There's always a risk that they might not do the proper procedure. Then there's entrustment in contexts. So when we talk about the global north, the way medical education is conducted over there, the way established systems, established governments, stable economies conduct their educational procedures, it's very different from us in the global south. We have very different experiences. We have very different concepts about trust and entrustment. We have hierarchical and power situations. We have a collective society where trust is not just one person, trust is a family who will all cling to one doctor, thinking that this person is who I can blindly trust with everybody. So it's very different in different contexts. And the question is not whether we are bringing CBME to, let's say, Pakistan or India or Nepal, but whether we are able to realize that CBME has to be contextualized, and we have to develop skills and we have to develop methods to move it into entrustment territory. Otherwise, it's not going to be successful the way we want it to be. So here is what I plan to do today. We are going to clarify competence, trust, and entrustment. We're going to expose the effects of power, hierarchy, and the hidden curriculum on these journeys, which will also make us understand why certain practices are not the best ones to be exported as it is into other nations. Then we're going to understand how real entrustment decisions are used by using some cases. And we're going to apply a small trust sensitive EPA readiness framework to see if we are ready to actually go towards entrustable professional activities, or we are standing somewhere in the middle, and what alternative can we have. So by the end, participants should be able to make entrustment decisions more transparent, more defensible, and more practically useful, instead of just having checklists or just developing softwares that we are doing CBME or we are doing EPAs. We need to understand the underlying practical implications, the underlying defensible things that we can do to inculcate this in medical practice in our regions. So here is my opening case for you. I would like everybody to vote on this. There's a house officer or a beginning internee at 2 a.m. in the night. The trainee has passed the pediatrics OSCE and clerkship exam. A febrile infant arrives with poor feeding. The supervisor is at home, which is 25 minutes ago. This is the first time the trainee is having such an experience. The nurse asks, Doctor, should we start our antibiotics? Now, would you entrust this trainee to initiate management with indirect supervision? Um, if you could please write in the chat yes or no. Okay, so a lot of people have said not really or no. Some people have said maybe. So, what is the thought process behind maybe, Dr. Elizabeth? What do you think? What would be the situation in which you would trust the internee?
Okay. Well, I can say that probably faster than typing it. I would
Yes,
say
definitely. It's good to see you.
okay, nice to see you too. I guess it would depend on the relationship that I would have with a trainee like that, and just a single, assessment, having mastered a single or two different assessments wouldn't be enough. I think I would also need to know more about the person before I can make a judgment on it.
Thank you so much. Thank you, Dr. Elizabeth. That's such wonderful input. So, as Dr. Elizabeth has said, which is very justifiable, that you can't just judge this person on one assessment, and it would depend a lot on the relationship we have with the trainee. For example, have you ever seen the trainee deal patients in the ward? Do you think they're a calm person? Do you think they're somebody who know how to give medication? So once you have been observing this person over time, you might actually indirectly supervise them. You might be able to trust them by calling them and guiding them, and they might be able to do something. On the other hand, it is a risk because this is someone who has just cleared an OSCE and has just passed the clerkship exam. And in a lot of instances, in a lot of societies, a lot of places, for example, in my own country, we have a very high load of clerkship trainees. So a lot of the time, we're not directly in contact with everybody except for their exam results. So I can understand when people from Pakistan or our context will actually say that no, we're not going to trust them, because we have very limited exposure to actually say that I can trust a patient out of a class of 350 or 250 medical students. It's quite hard to say that I can just trust somebody to do something alone. However, if we have the provision of small group training, or we have actually seen the person, it changes the scenario. So this is one of the things we need to think about, that when we discuss competency-based medical education and EPAs and entrustments, we are all talking about different contexts. And you may find that one thing which is working effectively in the literature and which has worked effectively in the Netherlands or Canada or the UK might not be acceptable as is in some other part. So what is important is that competence is necessary. It is not sufficient. A person can know, show, and still not be ready for unsupervised responsibility. Like most of you have said in the last slide, that on paper and technically also, this person is competent because they've given their OSCEs, they've done their clinical wards, they've done their skills. So they do have that certain competence. But that is not sufficient for you to trust somebody at 2 a.m. with them unless you have already seen other encounters with them, unless you have observed behavior, like Dr. Elizabeth said, that trust is an observed behavior. You've looked at other encounters with the person, you've made a judgment about them, about their skills, and you know that in a particular context they can work. So competence will only work effectively once you have trust developed. And the trust is developed when the supervisor believes in safety to allow a person to work somewhat independently. Once these two territories are explored, the third thing is entrustment, which is permission to act with a defined level of supervision. So when you are entrusting somebody, you have to see the task that is there, the risk level of that task, the supervision level that is needed. For example, in this particular case, it was a febrile infant, and I didn't specify the severity of the issue. So let's just assume that it is somebody who comes with a fever and has no other morbidities in the middle of the night. So maybe you can trust the trainee to work with indirect supervision, where you can talk to them and guide them remotely. However, if this patient would have been presenting with febrile fits, or if this patient would have had a heart condition and would have been febrile, um, direct supervision or direct intervention of the supervisor would be more necessary, because you are accountable for what you're teaching or how you're entrusting your trainee. So entrustment levels will be depending on the task, the risk that there is, the level of supervision, and the accountability that is required. So competence is just the first stepping stone. What makes competence work practically is not how well the assessment is working, but how much of trust you have developed. And that trust then translates into entrustment decisions. So, building on all of this, Olit and Kate described EPAs. I personally think that this is a very good framework. It is debatable, like all frameworks in medical education. Um, the entrustable professional activities, they are one of those that translate competence into accountable clinical work. So the logic behind EPAs, very simply described, is that there's a piece of work or a professional activity which is assigned a level of trust based on the supervisor's relation with uh, the trainee. And that level of trust has to ensure patient safety. It's based on risk levels. So it's not a checklist of traits. It's not a checklist of how fast I can suture, or how many cases of gallbladders I have done, or how well did I score in my MLEs. It is a meaningful unit of practice that integrates multiple competencies, and it integrates the trust of my team and my supervisor in me to work at a certain stage with them, and then as time passes to work independently without them. So EPAs are something that I have worked with, and I have been asked to train people to do them, and I have been asked to collaborate with people with them. But we have to think very hard and very thoroughly on this, that are we prepared to develop EPA units? Is the level of trust and entrustment as a department, as a unit, as a hospital sufficient that you can actually move over from competencies and checklists towards this sort of education. If it is not there, that is also fine. I do not say that everybody needs to go into industrial professional activities and it's the only way ahead. But I do think that the concept of entrustment in itself is something that we can all somehow contextualize and use within our clinical training. So, entrustment, when we speak about it, it is graded, it is not binary. I asked you a very simple question about yes and no, and then I got a multiple grade of answers, and then some of you said maybe, and then you talked about why you would or why you would not trust that particular trainee. So, entrustment moves in scales. The very simplest scale that was described in the beginning with EPA literature, again by Ole and his companions, was that level 1 means that it is just observation. You're only looking at, or you're only trusting a trainee to look at what you are doing. Level 2 is when you will directly supervise, with you being involved into that particular action the trainee is doing. Level 3 is indirect supervision, that you are guiding the trainee, but you might not be present in the same room. You might not be present in the same vicinity. You might be on call, you might be on Zoom, you might be giving them some sort of directions, but there is direction by you. Level 4 is unsupervised practice. This is when you have a level of trust that you can actually trust your trainee or your student to do something without your help. And then the last level, where we think that somebody is now moving on towards expertise, is where we allow them to actually not only do things independently, but also teach other people or supervise other people into doing those things. So as you move up the scale, there needs to be evidence, not optimism. You have to have evidence of this trust. So there should be some sort of documentation, there should be some sort of observation skills, there should be some sort of workplace-based assessment, which is showing the progression of the trainee from level 1 towards level 4. So the person who was just observing initially, have they improved enough that they can act as your assistant in a surgical procedure? Have they excelled enough that they can actually do an appendectomy independently? Are they now competent enough that they can actually teach a junior batch or guide somebody else? So moving up, you have to have evidences for this. This is where the EPL literature makes a lot of sense, and it makes a lot of help for clinical training, is that it asks you to not just trust somebody blindly, but to build up on evidences. So every level will need some sort of evidences, including observations, including discussions, including feedback, 360 feedback. However, your hospital decides to check the quality and the progression of your clerkship, there will be actual evidences to move up the scale. And the scale in itself can be staggered according to your context. So, for example, in our context, there's a lot of unsupervised practice. I did work for EPAs in basic health units in Pakistan. So while we were trying to make our units of EPAs, while we were trying to decide on the EPAs, a big question came that we cannot just adopt the scales that are given in Western literature, the scales that are given from CanMeds, the scales that are given by Ole, because we reach the unsupervised practice level, unfortunately, very commonly. Because in basic health units, you have trainees who have just had experience after their house job for a few years, and they are now independent. So how do we tackle that? How do we stagger their supervision? So we had to modify the scale into one where we had to bring unsupervised practice a bit down, and we had to add a few more stages in the middle. That if the trainee is competent enough to talk to you on the call and he can do it, if it is needed that they have to refer to the tertiary care hospital. So contextually, we had to develop the scale slightly differently, and this will vary in every context. Now, what is the anatomy of trust? Whenever we're making an entrustment decision, supervisors don't judge the learner alone. They're judging a whole system of relationships and risk. So there is foremost the task that we are giving. Then there is the trainee. the personality of the trainee. Are they positive? Are they somebody who is willing to learn? Is it somebody who expresses humility? Is it somebody who is humble? What is the context? Are they working in a remote area? Are they working in a tertiary care well-equipped setup? Are they working in a rural area? Is it an urban area? What is the relationship between all these things and the supervisor? So an entrustment decision is going to be based on all of this. It's not just going to be based on how I think my trainee is faring or how I think that one task is going to be performed by this person. Um, Trust is deeper. It is not just based on checklists. Like I said, it is not just going to be based on clinical competence. You will have to see the characteristics of the trainee also. Is he or she someone who can work in a team? Is he or she someone who is nice to patients? Can they handle patient care? If there's a situation where the patient is aggressive or where the attendees are difficult, can they fare on their own? So all these things become central when we're making entrustment decisions as supervisors. Now, Ole suggests again in the article the ingredients of a entrustment decision about an acronym called A-RICH. This is a lens which helps supervisors describe trustworthiness beyond technical skill. So A is for agency, that the trainee that you are trusting, they should be able to own patient care. They need to take initiatives. R is for reliability. They have to be someone who you have observed consistently as being reliable, accountable, punctual, predictable, someone who follows through with the task you give them. They have to be, excuse me, they have to be having integrity. That is, they have to be very transparent about what is happening. Their approach needs to be patient centered. They need to be honest and truthful. The C is capability. I've marked this in yellow because I want to make a point here that obviously clinical knowledge, skills, and judgment are very important. But as you can see in this whole list, they are not the only thing. They actually come in between. The other characteristics make a very, very strong point for trusting somebody. And then finally, H is for humility. This is very important. Does the trainee or the student recognize their limits? Do they know how far they can go independently? Can they seek help early? Are they too reluctant to actually admit that they are failing? Or are they too reluctant to seek help? Because such situations don't fare well in medical education. We have to work together as a team. If we don't, something or the other can go wrong. So this A-rich lens actually gives you a sort of a background as to how to trust somebody in your clinical clerkship as a trainee. And then again, like I said before, you have to apply your own context to this. For example, in context of the global south, Malaysia, Pakistan, Indonesia, India, we are collective nations. Our culture is collective. We tend to live together. Families tend to be very well knit together. So when there's somebody who's ill, you have to look at not just the patient. You also have to cater for everybody else who will be coming. You have to cater to how to answer their family, how to tactfully put them in a safe space so that they don't interfere with the treatment, but still not hurt them and still make them feel valued. So all those things, they are now contextually part of trustworthiness that we have. So the A-RICH acronym basically makes us realize that it's not another checklist. It's a narrative judgment that we will make for every trainee when we're moving them up in the entrustment cycle. Now, the dilemma that is coming now and the problem that I think practically we face and we might face when we come to entrustment decisions, implementation of EPAs, and moving forward with CBME, is that this is just a tip of the iceberg. If you see above the water, you will see the scores, forms, checklists, the workplace-based reviews, the feedback forms, the different competence committee decisions about a person, how he has progressed, is he moving from the first level to the second. But below the water, there's a very deep layer. The iceberg is very large, which talks about hierarchies. It talks about reputation of supervisors, how they feel if their student is con consistently failing, or if they're consistently not moving from level 2 to level 3. What sort of reputation of the supervisor does that reflect? There are considerations about gender. Are we empowering genders equally? Is there some sort of equity disturbance? Are we preferring a certain gender? Are we not promoting somebody? Then there's familiarity. We tend to reward and we tend to practice and we tend to prefer those systems, those values, those procedures which we know. So, are we putting the unfamiliar things at risk by not judging them fairly? Are we leaving them under the water? Are we fearful of failure, fearful of getting blamed, of not trusting people, or of over trusting people? And then, obviously, one of the biggest parts of this iceberg is your local norms that I've described again and again, that the local power struggles, the hierarchies, the way your system is constructed. Can you actually interpret that and actually put that out into entrustment decisions? So, unless and until we surface what is hidden, entrustment cannot become fair. So, if we're expecting a fair sort of entrustment, a fair sort of way to conduct competence based medical education, to conduct entrustment based clerkships, we have to have these discussions before we start on these journeys. Now, one of the biggest struggles, which I think is all over the world, but it is more prominent in certain cultures, is power. Power enters before the learner speaks. So, hierarchy is something that not only can disrupt trust, it can also disrupt the evidence used to build trust. For example, if you are asked to observe the trainee of the head of your department or of the dean of your university, and you yourself are working under that same dean, and the dean is somebody who holds his position like everybody does in high regard and is somebody who is a prestige figure, and you understand that if you are repeatedly failing this trainee, or if you are making this trainee look like someone, or if this trainee is someone who needs more help, you might get into trouble. So, how are you going to actually build a relationship of trust over there? How are you going to make evidence which is trustworthy and honest when you yourself are fearful? How is there going to be a proper, clean, transparent value? So these discussions need to be thought about before we enter into the entrustment decision making. Learners may hide uncertainty to avoid looking weak. So, in a hierarchical system, which most of medicine is, I think, and it's more pronounced in certain areas, learners, to stop themselves from looking weak or stop themselves from being judged as failures, they hide their uncertainty, they hide um, their vulnerability, which again distorts trust. You cannot trust someone who cannot trust themselves. So, if a learner doesn't know something, those gaps need to be identified. That is not their failure, that is just them reaching out. But because of a power struggle, if the learner is silenced and they're hiding uncertainty to avoid looking weak, trust weakens. Confident trainees may look trustworthy before they are safe. So, again, this is one of those paradoxes that someone may, just because they look very confident, just because they speak or they are calm and collected in front of individuals who hold more power, um, we might do the policy of trusting them before they're actually safe to be entrusted at that level. Obviously, then comes bias. There might be a bias regarding gender, language, class, reputation, all these things. It colors judgment. It can distort trust. It can distort entrustment. And then there's fear in the supervisor and fear in the student. Sometimes supervisors undertrust because they fear blame or litigation. They fear that if they give independence to a trainee and that trainee errors, that error will fall back on them and they might be in a lawsuit, or then might be the one who is blamed. And this fear is actually very gripping. It is very genuine at times. And it is one of the biggest impediments we have to entrustment-based learning in the current scenario. That is the fear of actually entrusting somebody um, because of your own reputation or because of the fear of a backlash. And then there is the fear of actually on the other side, there's the fear of uh, over trusting. You will give someone the benefit of the doubt, even if they are not safe, just because you don't want to fail them. You don't want to look like the bad guy in the situation. So these are all power dynamics that need to be understood and identified in your society, in your ward, in your clinical setting, before you decide to move ahead with competences and EPS. Now, this is a huge paradox between trust and autonomy. When there's too little autonomy, you're not giving independence to your students to practice, to your trainees to work. Um, they're not going to grow. They're always going to be holding your hand. They're always going to be looking at you to help. On the other hand, if you give them too much autonomy, that's a safety risk for the patient. Like we discussed in the beginning, where your concern was mainly that you can't give that much autonomy to that house officer because at 2 a.m. at the night, nobody's nearby. It's a risk to the patient. So the trust autonomy paradox exists. We have over supervision, which is where out of our fears of letting uh, some harm happen to the patient, letting some harm happen to our reputation, letting some sort of problem, we basically make the learners become dependent. They don't have responsibility muscles, they actually weaken. And what is happening? The feedback is going to be performative. I know that I have to do workplace based assessments. I'm going to act as if I do things very well. I'm going to perform in front of my supervisor. I know that my supervisor is on my back and they're never going to let me go. And they're always going to be there. So it's more of a performance than an actual real life act that I'm going to be doing. The other issue is premature independence. Premature independence is when the patient safety is compromised. We give authority to somebody who's not that skilled. The learner is masking the gaps by their act of overconfidence or overcompetence, and the supervisor loses oversight on the situation. They think that's fine, let them grow, let them learn, but that is also dangerous. So, autonomy has to be graded in entrustment settings. As you move ahead during the entrustment cycle, you give graded autonomy to your trainee along with that. It's not black or white. It's not like you're completely going to stop them and do everything for them, or you're going to completely give them independence and you're going to let them off. So with each level of entrustment, the scale that we discussed, there is some autonomy coming to that patient, to that person, and there's the caveat that if they are not on that level, that autonomy can be reduced. So at all levels, they need to understand that they're going to be having some independence in their clinical training. It will enhance if they do well, and if they don't, it will go back. Now, entrustment decisions are human judgments. If there's uncertainty, there's a clash between two people about a certain trainee or about a certain grading of the trainee, or the competence committee sitting and wondering if there's a trainee who is excellent with his clinical work. He's very good in all of his workplace-based assessments, but he has some sort of issues with the nursing staff, or he's not cooperative with his fellows. He's not a team player. So these are situations where we have to develop some sort of mechanism for grounded trust. So obviously, there's direct observation. You look at what the student has been doing. You look at their behaviors. You see the narrative comments, the feedback by other people. You see the case complexities they have been dealing with, but you also notice the things that are hidden. This is where the hidden curriculum comes in. So you have to see or observe or get word on what the team says. The voices of the team are very important. That is this person somebody who will help another teammate at 3 a.m. in the morning if that person is not able to deal under pressure? Will he assist his fellows in working? If there's some sort of escalation going on? What is his behavior? Does he get aggressive? Does he go back? Does he support his team? Is he safe? Does he know how to develop safe spaces for them? So you have to see at all these things which are not visible, which are not going to be written down, but they're going to be there in the ward and in the hidden areas to actually develop grounded trust. And you have to see this trajectory over time. It's again, like Dr. Elizabeth mentioned, it's not a one-time decision. You have to see over time and over encounters how a certain trainee is behaving to actually give them or award them a certain level or a certain scale of training. So that is one of the issues I have with EPAs when we say that we should implement them everywhere. We need to first be prepared and be able to actually give this much time, thought, and energy to each trainee. We need to understand that it's not just about the checklists, it's not just about the procedure that has been mentioned, about the grading that has been done, but about the thought process of the supervisors, how they perceive entrustment, how they perceive trust, and how it's going to move forward. So, unless and until all these decisions are coming into your context, you're talking about them, don't actually just implement something out of the blue, because that is how these things are then, either they're half-hearted or they fail. So let's see this case. There are two trainees who scored 8 out of 10 on the same procedure. So there's trainee A who asks for help early, explains risks to patients, documents early, and reflects on uncertainty. And then there's trainee B who is very efficient. He works quickly, doesn't think he needs to call a senior. He appears confident, and he omits uncertainty in handover. Now, who would you entrust for indirect supervision next time and why? So please mention in the chat. Okay, somebody is saying trainee A. Okay, I'm trying to look at the chat. I'm sorry. Trainee A because he knows his limits. All right, Dr. Mona, yes, that's very important. Anybody else? Yeah, because he knows how to ask for help. Very nice. And because he documents clearly. Yes, so this is something which, so he is accountable. Thank you, Dr. Mona. That's wonderful. So, like most of you have actually identified, it should be trainee A. Um, the problem that happens is that you are seeing this on a slide and you can see the attributes of both the trainees that I've written. However, when you see this in practical life, they're both going to look more or less the same, and trainee B is going to look more efficient. Because in your ward where there are like 50 patients, trainee B is getting the work done quickly. He's not pestering the seniors. He is confident and he's giving the handovers as soon as he can. So we are liable to make a mistake over here and choose trainee B in reality, unless and until we see the other things happening around them. We have to see when he asked for help from his colleagues. Has he ever explained risks to the patient? Is there previous record of clear documentation? So all of these things are, again, this is the hidden curriculum at crossroads with your actual entrustment curriculum or with your actual curriculum. So all of them are intersecting when you are using a rich decision or making a rich decision. Okay, I think, I'm sorry, let me just, I've lost my screen for a second. Okay. So how do we make entrustment fairer? The question is that it seems easy to do on paper. Dr. Mona has also written, how do we detect the hidden curriculum? So this is my take on this. How you make your entrustment favor, how we can make entrustments favor. Is the task is not to remove judgment. We are going to be judging the patient. We are going to be judging the student, but it is to discipline that judgment. Always observe whenever you are asked to entrust somebody on a scale, whether it's measurement, whatever, Always do observations. Do not entrust what you have never seen. So don't rely on somebody else's judgment. Try to observe and see for yourself. Triangulate, use multiple moments, use multiple assessors, use multiple different contexts. Look at different contexts, look at different situations, look at how the person handled. So we cannot explicitly express the hidden curriculum, but if we see different moments, we see different people and how that particular trainee has fared with them, how he has treated them, particularly your paramedical, nursing staff, your patients. If you can get reviews from them also, that actually helps a lot with actually manifesting the hidden curriculum and seeing what sort of role modeling is going on, whether this doctor is treating them properly, whether he's been punctual, whether he's been respectful. The third thing is narrate. It's very important to not just have numbers on your paper. Record the reasons. So whenever you're developing entrustment checklists, the do not underestimate the power of the narrative comments. Record the reasons why you have made an entrustment decision. Why did you feel that this trainee is still at level 1 and it should not be at level 3? Do you think that they lack the maturity to ask for help? Do you think that they're not properly documenting things? Do you think that they perceive failing in something as a weakness? So have all of that prepared as part of the narrative. And then calibrate. Discuss borderline decisions with other peers. See if they see the trainee in the same light. See what they suggest about a borderline case. It's always helpful to have more people on board. And then create safe escalation and no blame help seeking. Create protective spaces for the trainee. You're not here to punish them. This is a sort of formative assessment. Entrustable professional activities are more or less formative. They're making you into a better doctor. Ultimately, they're making you into a safer practitioner. They're not there to judge you or punish you or to declare somebody as somebody who's always going to be at level 1 or somebody who's at level 5, somebody who's amazing. It's a trajectory that everybody goes through. So make it clear to the trainees that this is something which is part of your growth. If you want to discuss this, if you want to contest this, if you want to appeal, there is safe space for you. There is no blame. You can have help seeking whenever you want. You can ask our assistance. You can ask if you want to challenge the decision and logically come up with it, respectfully come up with a challenge. You are welcome to. So ensure that that culture exists and your trainees trust you enough and they can challenge this much of the hierarchy at least that they can talk to somebody who's senior. If that trust is not there, if those hierarchical and power struggles exist, making fair entrustment decisions is very, very difficult. So before developing a set of EPAs or a set of competency-based interventions, you need to look at the culture in your ward. Now, 5 sentences that can actually change that culture. Because I belong to the Global South and we have a hierarchical culture, which has its own nice things also. I'm not saying that it's always negative. There is an immense respect we have for our seniors. There's a sort of hierarchy that helps each other also, but there is a certain amount of fear. There's a certain amount of reluctance between junior and senior trainees, between junior and senior faculty. So 5 sentences that can actually help in trust-sensitive supervision through small repeated behaviors. Observe the trainee. Tell them that let me watch one case so I can support your next step. When you're telling them that you can support their next step, it lends some sort of trust to that person that I am being watched so that I can be helped. I'm not being watched so that I can be judged. Name the particular thing that you want to entrust to somebody. So what I trust you today with is to deliver a safe patient handover. What I trust you today with is to effectively be able to apply an IM injection. So name the skill or the competence that you are trusting so that the person is clear that I am progressing in this domain. Ask them the relevant questions to establish where they stand and how much help they need. What could happen or what would be the thing that would make you call me immediately? What are you afraid of in this procedure? Where do you think you always need help? So if you're offering a helping hand and you're asking, then that reluctance to actually speak in front of a senior or to look weak in front of someone, that starts melting away. It takes some time, but small repeated behaviors will help. Calibrate everything. Um, Give your calibration and ask for their calibration. So let us do a procedure and compare what we both noticed. What do you think went well? I'll tell you what I think went well, what I think can improve. I'll share. You tell me how you want to go ahead with this. So there's a shared environment of entrustment then. And then commit to the next step that the trainee can go ahead to. So your next autonomy step is going to be that you are independently going to pass a nasogastric tube the next time we have a patient who comes with a certain condition. So a culture of entrustment is a culture where all your expectations, they are not withheld, they are spoken out loud. All your procedures are clearly documented. Everything is as clearly discussed as possible in the open, whether it is explicit curricula, whether it is expectations of behaviors in the ward, role modeling, it is still more or less explicit so that trust can actually be fostered. Okay, so this is my take on EPAs that before implementing intrustable professional activities, prepare the culture that is necessary for them. So this is a trust to entrustment readiness framework. I would recommend that I've been repeatedly saying this. First of all, look at your culture, look at the hidden rules of your ward, things that are unsaid but everybody knows exist, name them or enlist them and see how you can actually, which of these help in entrustment, which of these are impediments to it. So you need to be prepared before developing a framework that which of these are going to help you and which of these are going to create problems. How are you going to handle accountability? How is it going to escalate? Who is going to be responsible if your trainee does something wrong? Who is going to be answerable? So this needs to be documented and discussed beforehand so that both the supervisor and the trainee know safe escalation. Who do they need to refer to? Where do they need to go? How is it going to proceed? Decision making, how does it work in your environment? Who holds the decisions? What are the standards? How are you going to deal with an entrustment committee? How are you going to make shared decisions? All these things, they need to be discussed before. Direct observation needs to be made a part of your daily practice. So how much of workplace-based assessment, which type of workplace-based assessment is practical in your field? How much of it can be done in your ward? What can you do? All of that needs to be discussed. And then obviously, relational issues need to be discussed also. That how can you give psychological safety to your trainees? How can you ensure that they feel safe and secure while they are discussing issues with you or with your colleagues? What sort of provisions do you have for someone who burns out? What sort of provisions do you have for a trainee who fails, who is let's say, whose autonomy is decreased because of something that they've done wrong? How are you going to deal with that? How are you going to deal with people in anxiety and stress? How are you going to deal with supervisor who has not ever had somebody telling them that their trainee is not capable enough to move to the next level? So all these discussions regarding psychological safety, regarding providing a safe space for everyone, they need to be done before moving ahead or thinking about moving towards EPA or milestone frameworks. So this is my technically this is my last slide. It's just a starter pack, something that I would recommend. It's an action plan that it's small enough to begin, but it's serious enough to change the culture. So if you want to move towards entrustment, this is what we tried when we started with one program of EPS. We had a month of discussions where we just ran focus groups with supervisors and trainees and finally students to know about their concepts of trust, autonomy, and supervision. So just listen and understand the culture of your institution, of your city, of your environment, of your government, so that you can see that what can you explore, where you can stand, and what you can do. The next 1 month is for designing. Select 2 or 3 very low risk EPAs, which are not life threatening, which are things that can be easily implementable. design the supervision rules, design the escalation rules, make sure you have fallbacks at every step, make sure you have checks for every assessment. And then after the first 60 days, you start with a pilot. So observe, narrate, calibrate, and review the entrustment decisions that you are making every month. So every month is a safe net. If it is possible and you have enough faculty, it is ideal to do it every fortnight so that you know what your trainees are getting into, what they're doing. So always start with your culture, always start with observation, not with forms and softwares and with immediate reforms coming up. So in the last 5 minutes, these are my takeaways. That competence is something that opens the door. Trust decides how far it opens. So always remember that where clinical skills are concerned, competence is what we talk about, fair assessment is what we talk about, but they're not enough. We're dealing with human health, so trust is a necessary component. Autonomy is something that you have to grant deliberately. It is not something that is a right. It is not something that you give accidentally or you give preferentially. It has to be graded. It has to be given deliberately to every trainee at different levels. And EPAs and CBME work only when the culture of supervision is ready. So I think one of the biggest struggles in our regions is that we have varying cultures within cities and within provinces, and then we have varying challenges with supervision. So we're not completely able to adopt these frameworks because our supervisor culture has not changed, and we want to just go on moving with implementation at trainee levels. So that is my discussion and takeaway for all of you. Thank you so much for being such nice listeners. If you have any comments or questions, please let me know. Final reflection is, what is, in your opinion, one supervisor behavior that you think you want to reflect on or change in this week? So Dr. Shabi has given a wonderful comment, which I'd like to talk about also. And that is that competence-based professionalism is what we need. And I think that is the crux of everything, that unless and until we are behaving in a professional way, we cannot actually move ahead in anything. And competence-based professionalism, and in that professionalism, we need to define what is trust, what is entrustment, how we professionally carry that out. And I think that is the way forward. Yes, Dr. Elizabeth has said this, and I second this, and this is what I think we need to talk about more. That before we move on to any sort of implementation, which is the, let's say, the vibe right now, that, everybody should move to competency-based medical education or they should move to EPS, we need faculty development. And faculty development and discussions on professionalism are something which I think are necessary all the time. They are never ending. They are something which should be part of continuous medical education, because we evolve and we grow and we learn with each other and we learn with the faculty. Anybody else who has any comments or any questions, please?
Yes, Assalamu alaikum.
Assalamu alaikum, sir. You are
My
audible, sir?
question, yes, can you hear me? I am audible.
Yes, sir, you are audible, please.
So my question, rather than a question, but just want to know, there is a lot of mismatch in between the Western world and the underdeveloped countries like Pakistan. Especially, I'm from Pakistan, so I'm naming the country as a Pakistan. Lot of difference of resources, lot of the differences of the behaviors of the student as well as the supervisor. how to match these all the ideal situation in our society. So I want to know what your take off on these, how, because there's a lot of difference in the theoretical and the ground reality. When we see the workshop, we go to the workshop as a supervisor. There is a lot of the literature. We have to be the angel. The student also should be an angel, and the supervisor also should be a super man. So, but on the ground, there's a lot of difference. Behavior. Uh, if we ask any task to our students, they usually put their demands because of the low salary, extra work, no facility, no security, and they sometimes say on during round, sir, how you can demand these situation, these things well, while you cannot provide the security to us. We are suffering a lot of the things during duties, and you are asking about the ideal treatment provide to the patients. So I think my question becomes very big.
Thank you, sir.
So
Nini, sir, thank you so much. It's very relevant. So first thing, it is important that I was talking about this, that we have to understand our context and our realities. We have to understand the situation in which we are. So just because some other region is successful in implementing something doesn't mean that it will translate in the same way in our region. Particularly, you're talking about certain contexts of Pakistan. So yes, one of the important things that we have to understand is entrustment and entrustable activities. They start with uh, having trust. Trust is something that is only earned if you are in an environment which is psychologically and physically safe. So, unfortunately, this is something which I have had discussions and debates with senior faculty also in different parts of the country. There are certain regions in Pakistan which right now do not ensure physical safety of the doctors uh, because of certain incidents that have happened. Psychological safety is far ahead. But when we have trainees or we have people working where they are at the risk of their lives, I think it is unfair to actually put them through more trials and more tests. So we have to look at our ground realities and see what framework best we can suit in our individual environment. How can we train our faculty to work in that particular environment and not look at, other shells which can actually be implemented. Once stepwise things are better, then maybe we can contextualize and see some form of entrustment or maybe some competencies that we can use, because some things unfortunately are beyond our control. The government, the way security is being handled in our countries, the rapid changing of policies, the influx of patients and poverty, these things are actually things that medical professionals cannot work directly with. These are things that come into our plates. Like, and these are things that are very, very responsible for our behaviors, particularly when we have trainees who are not paid and they're working in our hospitals and they're dedicating their time to patient care. So pressurizing them or trying to reform them into something which whose necessary ingredients we don't have, I think that is unfair to everyone. So we have to ensure that we have the necessary ingredients first and then we implement that step. Otherwise, whatever best we can do for them in that particular scenario and that particular context, that needs to be applied. Okay, Dr. Saira has written something that in the global south, we have one track of doctors that sidesteps the hospital based training. These are fresh graduates who are appointed as medical house officers right after house jobs. Some work in peripheries with no supervisory oversight. EPS and entrustment activities need to be instituted in undergraduate years and house job. All right. Thank you so much, madam. I think that's a wonderful take. I am not in support of EPAs in undergraduate activities personally in Pakistan. Uh, if we're talking about Pakistan or majority global south regions, because of what I have experienced and the way I've seen things, we do not have similar curricula implemented. We do not have uniform training in all medical colleges. We do not have a similar standard or a similar board. So it's very difficult to actually standardize training for undergraduates when you have such diversity. Diversity to the limit that your private medical colleges have all the provisions which are present in Harvard and Stanford, and there are certain areas and remote government colleges which might not even have provisions such as clean water. So I think EPAs in undergraduates has to be something which we have to discuss very, very carefully. It has to be something which has to be thought at a national or maybe a regional level, like it was in the Netherlands, like it is being discussed in Canada right now. It's very tricky. At the level of house job, yes, we have implemented EPAs at the level of house job for basic health unit competencies. But that is because house job is somewhere where we have relative freedom in our own particular hospitals or domains. So yes, you can easier to contextualize these things in house job levels, and I would recommend that if you have that sort of discussion going on, run focus groups, have sessions, design a few EPAs, and try it in your house job. I think that is something which would be work really, really well. But for undergraduates, I think we still have a far way to go because we need to train our postgraduate and faculty to think in terms of entrustment before we bring it to undergraduate level. Yes, sir, somebody has raised their hand, please.
Dr. Hassan?
Yeah, Sakina, yeah, I'm unmuted now. A very good talk, Dr. Komal, very interesting and very helpful for the present trainees as well as the assessors. You know, madam, we were brought to a training where we assisted one, we saw one, we assisted one, and then we did one. That was the motto of the Royal College of Surgeons, whose tutor I am still. So that training has all gone. Now, when you assess a training, number one, you should not be wearing the boots of an assessor when you are assessing a training. You should put yourself in the days when you were learning. And so now all the procedures which we used to do by seeing one and assist one and do one, they all have been broken down. For example, if you're doing a hernia, we first tell somebody who's doing a hernia under local how to instill local anesthetic, or even before that, how you prepare the patient. And then step by step, it's a very gradual progression of knowledge. See the levels and the layers you are encountering, and then give them the knife in their hands. Because surgery is one thing which you cannot reverse. You can write Panadol, you can write Tramadol, you can write Saradon, but if you have inflicted a surgical wound and a wrong operation on somebody, you cannot reverse it. So it's very, very important, and human factors do count. I was impressed when everybody said the trainee A would be, recommended. Yes, you have to be very, very conscious. But on the other hand, you don't have to be overconfident and do things which you are not confident with. And it's a human factor. Surgery, and in fact, all these procedures which you're talking about, even giving an injection. I'll give you a living example. I had my second injection intraorbital of an epistin injection 2 weeks ago. The first injection was very smooth. The second injection made me, sort of jump. So it's a human factor which also counts. The more numbers of normal procedures you see, the more you'll get confident with, and the more your expertise will improve. And you should always be aware of your own sort of disabilities or weaknesses, and try to address them after every procedure. Why have this patient got a hematoma after doing a hernia? Probably I did not do good hemostasis. This sort of thing will help. And I'm sure, I was very impressed with the classification, and I wish I was in this age group to teach surgery, which I am still doing, but very impressive. But, both the trainee and the supervisor need to acclimatize themselves with the present environment. And I was surprised that you're still having in Pakistan, people are not being paid. I attended a conference on medical education way back in India where house surgeons in one institution had to pay 500 rupees to do a house job, and in Maharashtra they were being paid 1,000 rupees to do a house job. So that's very, very important. Thank you very much.
Thank you very much for your wonderful insight, sir. Thank you very much, everyone. You have all been a very wonderful audience. A very great thank you to Dr. Shabi, Dr. Elizabeth, Dr. Sakina was always helpful. It's always wonderful to be on this platform. Thank you so much.
Bye.
Thank you, everyone. Don't forget, we have an upcoming webinar on August 15th by by Brother Hasnain Baloch. He will be talking about mobile collaborative informal learning. So please don't forget to join us August 15. I will be sharing more details on our WhatsApp group. And also, please don't forget to put your name for the certificate so we can send it to you as soon as we can. If there are no questions, we will end. And thank you so much, Dr. Komal. I really enjoyed your talk today. Thank you, thank you. Not having any medical background, but knowing that the doctors are being taught to be humans and perfect before they would practice on me. So thank you so much. I really appreciate it. Thank you, everyone.
Thank you. Thank you.
Bye-bye.
Bye.
Goodbye.